Hello, everybody, and welcome. It's my great pleasure today to introduce Professor Irene Tracey. Irene holds the Nuffield Chair of Anesthetic Science and is head of the Nuffield Department of Clinical Neurosciences at the University of Oxford. She is one of the world's leading pain neuroscientists. She's pioneered the study of brain mechanisms underlying pain, analgesia, effects of expectation, emotion, and context. Her work has contributed to a fundamental change in how we view pain as an emergent experience rather than as a simple product of nociceptive input or peripheral stimulation. Continuing in this theme, she's turned to understanding the neural basis of altered states of consciousness during anesthesia, a subject that's remained as mysterious as it is important. Irene has won many awards, including the Patrick Wall Medal, election to the Royal College of Anesthetists, election to the National Academy of, or the Academy of Medical Sciences, the Feldberg Foundation Prize, and she really has a penchant for leadership. She's a great supporter and advocate for her field. So after she studied biochemistry and MR spectroscopy at Oxford's Merton College and later at Harvard, winning several awards, top first honors, the Gibbs Prize, and a Wellcome Fellowship, then she returned to Oxford to co-found with Professor Paul Matthews the Oxford Center for Functional Magnetic Resonance Imaging of the Brain, otherwise known as the FMRIB. And that's now, of course, famous in our community for the software with the little bony fish on it, as well as the biobank study and other things as well. She directed the FMRIB from 2005 to 2015, when then she moved to serve as head of department. Starting this fall, she will be the warden of Merton College, which is one of Oxford's oldest colleges, dating back to 1264. Throughout this illustrious service, she remains a champion of our field, of young scientists and of women in science. She is warm, constructive, generous with her knowledge, and she is a lovely person. I am grateful to have her as a colleague, and I am sure that we will all be enlightened by her lecture today. Please join me in welcoming Professor Tracey.
Well, thank you, Tor. That was a very, very sweet and overly generous introduction. Thank you so very much. And thank you also to the Programme Committee for the OHBM for the real honour to come and speak to you today. And I'd also like to congratulate the local organising committee for doing such a super job so far with the meeting. I hope I don't ruin the wonderful meeting that it has been so far. So I think it's helpful for those of you who are not in the field of pain to sort of root yourselves in an understanding of how we define pain. The International Association for the Study of Pain is my pain equivalent of OHBM. And the definition that we use to encapsulate this very complex, multi-dimensional experience that is pain is it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So the key thing is you don't need nociception, tissue damage, to have pain. It is an emergent experience through brain mechanisms. And it's challenging because it is this multi-dimensional, hard to pin down and grasp concept. The textbooks, though, illustrate pain as if it's something really rather simple. You have things in the environment that we tend to think of in the thermal, chemical, or mechanical domain that hurt you. And those are transduced on your peripheral nerves through first-order connection neuron in the spinal cord up to the brain. So at this point, this is nociception. When the brain receives those nociceptive inputs, processing occurs, and that is where pain emerges as the subjective private experience that we've all had. So at one level, you'd think, how hard could it be to find the brain networks that subserve the hurt in pain? And after 20-odd years of burning and electrocuting and poking an awful lot of students back at the University of Oxford, I'm not going to be able to give you that answer yet. We're still on this journey trying to understand, is there even a network or something that actually can describe the hurt of pain? Or is this something that actually is more of something that we conjure and there isn't really such a thing as pain to find? We will see. So the challenge you have, now that you realise obviously this is how we define pain, this is where it emerges, is that in addition to that, it's also a very malleable experience. It's subject to mood, cognitive and contextual influences. So even with the same nociceptive input coming up from the peripheral nerves to the spinal cord, dependent on whether the brain, the substrate into which those nociceptive afferents are reaching, if it's a brain that is in a different depressed state or happy state, or is paying attention, or is distracted, or is having different expectations, that will powerfully influence how those nociceptive afferents are processed, and thereby the network that emerges is different, even to the same nociceptive input, and if the network is different, the pain experience is different. So that's good because it means you have basically the pain that's appropriate for the situation you're in, because why do you have pain? You have pain in order to alarm you that something in the environment is hurting you, so it drives decision-making and action. But it does mean that there's not a simple one-to-one mapping between the brain and the nociceptive input. It is a highly non-linear relationship between nociception and the perception that is pain. So before we move on to brain imaging, how do we currently and how actually do we mostly measure pain in the lab and in the clinical context? Well, we heavily rely on self-report, either sort of numerical rating scales. If people don't have language, then children will just point to a particular picture that best describes their mood, a happy face or a sad face. We can observe behaviour and infer from that behaviour how much pain we think the particular person is in. But this brings huge amounts of societal and cultural biases to the table that colour our judgment and our capacity to be objective about trusting or believing somebody's pain. If we don't have those, then we can look at indirect physiology. We can look at heart rate changes, pupil dilation, galvanic skin response. So indirect ways to look at the physiological impact of having something nociceptive hit the central nervous system. The problem, though, is these are all subjective to a large extent, and that really does lead to a limitation in the diagnosis, in treatment, multiple failed clinical trials. Even the lawyers are all over this issue in terms of courts of law, failed claims, and insurance and legal complications. So the subjectivity, although it will always be the most important thing that you want to understand and capture, leads to problems because it can be very much influenced by many factors like mood and context, and as I've described in the previous slide. So that's where really we want other tools, we want objective tools to try and get us a better understanding of what is going on behind the scenes of this subjective report that might help us explain why that particular individual has a certain pain of a certain type. You'll never objectify a subjective experience, and this is a common misapplication or misunderstanding in, I think, the pain imaging field largely as well, certainly in the media, in terms of what brain imaging can do as a lie detector and et cetera, You'll never fundamentally objectify a subjective experience, but you can certainly use it to help better explain what is the underpinning set of mechanisms that best relate to that then report of the experience the individual has. And there are many situations where we would desperately need and want to have such objective information. So whether it's the anaesthetized patient, whether it's the demented elderly person who can't verbalize their pain, whether it's a baby who up until recently we didn't think had a developed enough cortex. Wonderful session just now in the Brodmann's areas, and again from early histology and anatomy in the 18th century, although wonderful, caused a problem for the whole neonatal pain field because it assumed that the cortex wasn't developed enough to experience something complex like pain, so we don't need to worry about the babies. And that has held firm and true really until the last decade. Absolutely staggering. So again, understanding in the baby's brain what is going on. And then certain conditions where again we have our biases about not really trusting somebody's pain. Let's take this situation here with this hand. Looks perfectly normal x-ray, doesn't look like there's any structural damage, but if I told you that that patient had excruciating pain in their hand, you'd be slightly judgmental, you'd be maybe a little bit disbelieving. But again, the complexity of the damage to the perception is such that you cannot possibly make a call about what pain somebody must have based on what you can visibly see in the periphery. It's just too complex. So we desperately need tools to help us, and that's where imaging sits. The other thing you need to understand is that we, again, in the pain field, disambiguate acute pain from chronic pain. So acute pain is, again, your alarm system. It's great. It's good to experience pain because it tells you something is hurting you, you better move away from it, you better remember what caused it, and you better go and seek treatment to alleviate it. Chronic pain, on the other hand, things like osteoarthritis, pain due to a neuropathy with diabetes, fibromyalgia as examples, is defined as pain that outlives that good, healthy warning system of acute pain. And we generally put about 4 months as the time period that if you're still in pain, after 4 months of normal tissue healing time, you will be defined as having chronic pain. It is now in the new International Classification for Diseases for the first time being defined as a disease in its own right, because chronic pain is something different, very different biologically, mechanistically to acute pain. And that's the new paradigm shift and model that certainly we've embraced in the pain field. And again, I encourage you to think about it. It is not as simple as just a continuation of acute pain. It's a whole new set of mechanisms that we need to understand and target. 1 in 5 of the adult population have chronic pain. It costs about $600 billion per annum in the US for the treatment and management, and people not going to work because they've got migraine or they've got backache or they've got some other pain condition. In Europe, it's about 200 billion euros. And it's basically one of the largest medical health problems in the developed world, and we don't really have very good treatments to fix it, partly because we've had the wrong model. We've been trying to fix really the acute pain mechanisms, thinking that will alleviate the chronic, rather than understanding that we need new biological understanding of chronic pain, and that's what we need to target. And that's the era that will be coming forward in the next decade. So I'm very optimistic about how things will improve. So there really is a key role, hopefully by now you'll see why we image pain. There really is a key role for neuroimaging to help us understand acute pain, just as an interesting question in neuroscience, but also this really important clinical problem, chronic pain. And today I'm going to mostly focus on the sort of basic neuroscience of acute pain with a little bit on the chronic. If you want to read more about the mechanisms for chronic pain, there's a review I've written that you can read there. So when we go back to the very early days, these are the first 2 publications that were generated in the first sort of foray into trying to image the brain in pain, done back in 1991. One by Kathy Bushnell's group, and one by, indeed, the great Carl Friston and Frakowiak, and Anthony Jones, who's a rheumatologist. And you can see they're pretty crude. They're blob maps, largely PET, but it was exciting. You could see things active bilaterally, more active than if you just gave a sensory, non-painful stimulus, and that was about as good as it was. We have this patriarch in the pain field called Pat Wool, and sadly he's passed away. He was a very acerbic man, to be quite frank with you. He didn't hold or mince his words when he had judgments about things. And around the time those early pictures were coming, he made this comment that every major imaging centre in the world has published pictures of the distribution of activity in the brain when the subject is in pain. The pictures are spectacular signs of contemporary technology, but their interpretation by puzzled brain experts has often lurched back into 19th century, when each bit of the brain was given a separate functional label. A highly satisfactory way of explaining the new data in terms of localization of function, and is marred only by the fact that there is not a scrap of evidence for these fantasy labels. Well, I hope to convince you that we do have now some evidence for these fantasy labels, and some of the ways that we have gone about doing it, I'll describe in the next series of slides. And his view, I think, is still relevant today in terms of how we should think about pain. He said pain is not just a sensation, but like hunger and thirst, it is an awareness of an action plan to be rid of it. It really was linked to this concept of awareness and action and decision making. So how have we gone about dissecting pain beyond these fantasy labels? How can we break down just the blob maps and find out which bit is doing what? Well, one of the early experiments we did was to, rather than just burn people and see what was activating, use a paradigm and try to dissect the network into dissociable components that we could better label in terms of what function of this multidimensional experience of pain they were serving. And the way we did that was to use a very simple Pavlovian conditioning design. A light predicted a certain stimulus: pain, warm, nothing. And it simulates this concept that pain in the good alarm system way is a very adaptive thing. You learn, like this chap here, not to touch a pan on a stove. You don't remember when you learnt that, but you don't do it, because pain is a great teacher, but nobody wants to turn up basically to its lessons. That's the problem. So for the good acute pain, everyday pain, it's highly adaptive. For the chronic pain patient, it's highly maladaptive. For this poor woman who's got a back pain problem, she has to pick up the basket of washing. She anticipates it's going to hurt. She's anxious about that. She has fear about it. She might even, in a new concept of a Bayesian brain, have some predictive coding and some priors. Either way, that's going to change the substrate of the brain into which those potential nociceptive afferents are going to arrive, and therefore they'll be processed differently. And so it can really exacerbate things. So what we did is to do the design in a certain way, and we were able to show, indeed we could, in structures like the anterior insula, Brodmann's areas 9 and 10. These regions, which normally we would see active if we burnt somebody and it was painful, now were active even before the stimulus was given. They were there to anticipate the fact that something impendingly horrible was going to happen to you. The regions like the more mid-insular and the more mid-anterior cingulate were active in response to the actual nociceptive arrival. We also were able to show, and I think that was what was neat back then, quite a long time ago now, was that you could extract from the blob maps the time courses and you could look at learning. So what you could see here, this is the signal from the yellow region, which is the anticipation of the event. And you can see the first few lights, they didn't know the rule, but as soon as they learnt the rule that red meant they were going to get burnt, up goes the learning signal. Same for here. They don't learn here, and then they've learned. Whereas in the receipt of the nociceptive input, obviously the bold response goes up straight away. So that was quite a nice way to show how you could start to dissect and start to get a bit more of an intelligent insight into what the different functions were doing in the context of, again, brain activation maps using slightly different paradigm designs. Other groups and our group, we went about trying to modulate the experience. We know from clinical and experimental experience that pain is modulated in terms of how it's reported. If people are more anxious and more depressed, they generally report more pain. And up until imaging was around and being applied, we didn't really know whether that changed the physiology of the nociceptive processing or did it just change the way they described their experience. So in some work that we did, we showed that indeed if we gave people more heat and we burnt them more, the brain becomes more active in sensory discriminatory emotional areas. But we could also make their pain report go up just by making them more anxious. To the same nociceptive input, we make them anxious and now it's more painful. And we could show that there was a neural amplifier in their entorhinal complex that was again tuning up regions like the mid-cingulate and those mid-posterior insular structures that we know are also the ones that just turn up to more nociceptive input. But I don't need to give them more nociceptive input. I can tune that up just by making them more anxious in the brain. Similarly, I can make people go from a neutral mood to a sad mood. And to the same nociceptive input, you can see qualitatively more brain activity. And if we subtract that, we can see that we've in effect turned up the volume of, again, these sensory and motivational, emotional regions just by making them more sad and dysregulating the normal regulatory systems. So I think, again, this is probably, in my view, one of imaging's greatest contributions to the pain field is to prove that there are neural amplifiers in the brain that physiologically make the nociceptive signals process differently and amplify them. And that happens, and that means that these factors, these comorbid factors that all chronic pain patients have, of depression and anxiety, really do need to be treated because they are as important as the nociceptive drive that is coming in. And that was very empowering, and certainly empowering for the clinical psychologists dealing with their patients. Karen Davis's group did some lovely work using what's called percept-related fMRI to say, let's not just worry about pain, no pain, let's look at the quality of the pain. Sometimes when you have a painful experience, if you've not had one, there's different qualities to it. And one of the common qualities is the sense, particularly to heat pain, of a prickling type sensation. So rather than focusing on the pain or no pain, let's deconstruct the quality of the pain and just go after one of the features. So in this one, focusing down on what region are encoding that prickling quality of sensation. And again, unfortunately, not more people have sort of gone into that. And again, I sort of clarion call for those of you who are in this field to sort of think about using these concepts a little bit more to start to help us break down the different qualities of the experience. So a really nice design and, again, another illustration of a different way of trying to break down these different anatomical networks into more digestible understandings of this, again, very complex experience. And then we had a set of experiments that were done by colleagues who were looking at, well, what is the difference between physically or nociceptively generated pain and non-nociceptively or centrally generated pain? I don't like the expression non-physical because, of course, all pain is physical by definition. So really this is non-nociceptive, but this is how it's been phrased in the field and certainly by the media. And some classic work done by Singer and Ray Dolan did studies where they looked at women's brains as they received a painful stimulus, so that you can see illustrated in green, and then when they looked at others who were experiencing the same pain, so they were having an empathic reaction towards another's pain. And this is something, again, as behaving organisms we're very good at doing, is feeling another's pain. And you can see to a large extent there is some overlap. And of of course, that unfortunately got a little bit hijacked by the community and slightly misunderstood, and there's been repercussions of that I will not bore you with. The important thing is what's different. So yes, there are overlap in, again, structures like the anterior insula, some of the structures in the sort of more anterior division of the anterior cingulate, but importantly, there are areas that were not overlapping and were quite distinguishing between physical and emotional pain. And again, you're going back to the more sensory discriminatory, lower, older brain type areas. You can use hypnosis and hypnotize somebody and see, well, what happens in the brain when somebody's hypnotized to experience pain. This is work done by Rita Hari's group. And again, you're back into the more frontal areas, being the hypnosis. But these areas around S2, posterior insula, mid-insula, be more preserved for the actual nociceptive-driven experience of pain. So again, all the time helping us refine our understanding of which regions are the key bits that are helping us understand pain. Well, if that doesn't help, maybe we can turn to babies. It sounds a bit of a dramatic step, but, babies, they can't contextualize, and they sort of are too maybe young, certainly if they're a day old, like in this experiment, to bring all the baggage of the emotions and the context and the expectation. So maybe by looking at a baby's brain would give us the simple neuroanatomy of the nociceptive networks, and that could teach us an awful lot. And that was partly one of the reasons for the motivation for this experiment, which was led in Oxford by Rebecca Slater, formed from some work done by Mariah Fitzgerald's work in London. And this required quite a set of developing of imaging to suit a child's brain in terms of bold activity. You have to manipulate, again, and optimize the TE and other factors like that. But what was absolutely extraordinary in this experiment, this baby is asleep, it's 1 day old, it's never experienced pain, it's born premature. The Sezgi Goskan, who was the student that did this work, was just absolutely fantastic at persuading these mothers to give over their brand new babies. Literally, she loitered outside the maternity suites on a Monday night with the scanner booked on a Tuesday morning. Her hit rate was not high, I'm not going to lie, but she got enough in 3 years to get these babies in. And do you know what? That surprised us all. They activate bilaterally pretty much the same as an adult brain. The overlap is extraordinary. Little less in the amygdala, little less again in the anterior insula and some of the frontal, but pretty much indistinguishable. So right from the day one, the network is primed and ready to go even when asleep and not able to contextualize or have had that life learning of the emotional baggage that we bring to the table. I think that's quite extraordinary. Another approach to try and understand this was to use decoding, so machine learning methods. And so again, I don't need to teach you, but in the spirit that we're in the World Cup, the scenario would be we put Ronaldo in here and we use our machine learning to find out whether he really does qualify for that free kick or not. All credit to the man, he got 3 goals the other day, it's spectacular. So the machine learning approach has been applied, and again, we and others have done a little bit in the early days, just looking at threshold stimuli. And what was it as you just took that stimulus above pain threshold to below? What was it that basically these classifiers could say these were the important bits that came to the table that made the quality hurtful? I think the most beautiful example of this, in fact, is Tor's wonderful work that he's done in this classic seminal paper in New England Journal of Medicine, where he took a lot of the studies that he'd published using physical nociceptive-driven pain, and then some of those studies I showed you on empathy or hypnosis or social rejection, where there wasn't a nociceptive drive, but people had a painful experience. And then using machine learning, worked out what was the signature that was specific to the physical nociceptive experience of pain. And again, it's interesting, you come to this sort of 2 dimensions of pain set of brain regions, the bits that are the sensory discriminatory, so S2, posterior insula, mid-insula, ventrolateral, mediolateral thalamus relaying, and then again a bit of the more emotional sort of cognitive awareness, so dorsal anterior cingulate. And what he's been able to do then is go on and use that signature to more carefully refine, well, what is the difference between this more empathic or vicarious pain versus physical pain? And is it that this signature can better disambiguate when you are looking at somebody experience pain versus receiving it yourself? So using this parametric modulation showed beautiful parametric modulation of the neurological pain signature with the temporal with the somatic pain stimulus, but not with the vicarious, and vice versa, calculated what would be the vicarious pain signature that could be modulated by increasing sort of psycho-type pictures of people being hurt versus not being modified by an increasing nociceptive input. So really beautiful work that now, of course, we can start to take into the patient setting. So again, this study just published last year, trying to work out what's distinguishing about a particular chronic pain condition like fibromyalgia versus other chronic pain conditions, and can we use these more global networks of signatures to give us a better understanding of the perception of these different qualities of pain, whether it's clinical or whether it's in different experiences. So I'm very excited by what the multivariate can do. We, working with our analysis group, Eugene Duff and Steve Smith back in the lab, took all of our clinical data sets and healthy volunteer data sets where we've done basically pharmacological trial work. So over the years, again, it's another lecture, we've done a lot of work to develop imaging as a useful tool for drug discovery. And so we had a lot of different data sets. We added, through collaborations with Matt Howard and Steve Williams in London, Dan Claw in Michigan, 2 other data sets. But basically, you've got a mixture of patients with different types of pain. You've got experimental medicine models with mechanisms that reflect mechanisms and symptoms of chronic pain patients. You've got healthy volunteers like you who were burning. And we're giving them classic drugs that we use to treat pain patients: opioids, cannabinoids, gabapentinoids. And then we're using, again, a machine learning, not only to develop a pipeline that we're using to help with our drug discovery, but importantly, we can come up again with what's common now about the signature that reflects the sort of set of regions that encodes the pain. And interestingly, which are the regions you'd need to switch off in order to have analgesia, irrespective of what class of analgesic is producing it. It just produces relief. And so we have these, again, and what's interesting is, this one particularly for the pain, it's becoming more and more consistent with what, again, other groups like Tor Group is doing in terms of the key sets of regions that seem to need to go into the mix. Again, it's always a little bit the 2 dimensions, the motivational, cognitive, as well as the sensory discriminatory. And again, you need to pull down both those divisions if you're going to have pain relief. Now, sort of the machine learning tools and studies like I've just shown you can come under attack, and I know you guys being brain imagers will appreciate that people get very worked up about reverse inference, and we must be very careful, and of course one should always be very careful in how you interpret any data, particularly in a reverse inference type manner. But I think we should also be honest with ourselves that we infer anyway from behavior, and sometimes we get that wrong. So it's not a unique problem to biological data or brain imaging data, the reverse inference problem. This is what we do all day, and it's certainly what's going on in the clinic, is people are making inferences about what that behavioral walking in with the dragging leg, and all the cultural and societal biases about what pain you really think that patient should be feeling, and they're probably just making it up or a bit neurotic. So this can be problematic too. So let's not beat ourselves up, and let's just continue to improve our ability to do these classifications, because I really think they're very powerful for helping us learn and teach what is the key components that will produce this hurt experience of pain. So far, we are clear that the relationship then between nociception and pain is nonlinear. It's not a simple one-to-one mapping. I can give you the same nociceptive input coming in on your A delta C fibers. You will get a bilateral set of brain activity, but you might not activate that. You might activate that in a highly variable manner to the same nociceptive input, dependent on whether you're depressed, whether you're anxious, whether you're worrying, whether you're attending or distracted, whether you have any injury. And so that flexibility or that malleability is what provides the beauty of pain, but what provides the challenges. And again, what we've been able to do in some of those early experiments is start to dissect that complex network and label which bits we think are doing the modulatory bit, which bit are encoding different features of that experience. Another way to attack it is to degrade the perception through a very dramatic pharmacological manipulation using, say, anesthetic agents. And it might come as a shock to you to learn that despite hundreds of thousands of general anesthetics being given daily, the anaesthetists don't actually generally look at the brain. They look at heart rate changes, breathing rate changes, everything but the very organ you're switching off. They not only look at the indirect measures, they look at them at a population level. So we don't have an individualized way of looking at your brain as you slide into a deeper state of anesthesia to know when are you not aware and when are you not going to feel pain. So when the surgeon goes in with the knife, you're not going to leap off the bed. Now, let me not freak you out here if you are going in for an operation soon, because they actually do a fantastic job. But it's probably because they take you very, very, very deep. So what you have here is the increasing dose of general anesthetic. You are awake at the start. If you went all the way here, you'd be dead. And at some point along this journey, you stop responding to them, you fall asleep, And then at some magical point at this stage here, they'll decide that you're ready to go in with the knife. And wouldn't it be nice if we had a brain-based metric for that? So there's a clear translational element to this, but the basic science element is we can learn a lot about which bits of the brain hierarchically get switched off to degrade the perceptual experience, any perceptual experience. Obviously, in my case, it's pain because that's very key for anesthesia. So we have done several studies over the years looking at that, and the one that I want to share with you just now is this one that we published a few years ago, where we just basically did the experiment a little bit differently. And I think it's a really good exemplar for the benefits of multimodal imaging, combined EEG, fMRI. What we did different here compared to what we'd done before with different experiments looking at anesthetics and how they switch off the brain networks was we slowed down the induction. So instead of just squirting the anesthetic in and you go to sleep in 10 seconds, we took 45 minutes to turn you to sleep. And throughout that time, we're bombarding you with painful stimuli, words and sounds. And we're watching each person's brain slowly switch off and degrade the experience of those sensory inputs. And we're doing this with EEG and with fMRI. And what we found was something really profound. As the propofol dose goes up, which is illustrated in black, the subjects are told every time they feel the painful stimulus or hear a sound, they're to press a button. And what you see in the blue line is when they stop pressing the button. So that's the loss of responsiveness. As soon as that happens, slow waves, 0.5 to 1.5 hertz, just like you mount in sleep, increase. And they reach a saturation level. So even though the dose of drug is carrying on, that's it for subject 1. When we bring the dose of propofol down, the slow waves collapse and they start waking up and pressing the button again in the scanner. In fact, we got very good at predicting when they were going to wake up and start pressing the button based on watching the slow waves come down. Subject 5 does the same, but their saturation level is of a different amplitude. Subject 6, same again. Their saturation level is of a different amplitude. This was not known at this stage in anesthesia, so this was clearly something very profound, but we didn't know what it meant. So what we did then was combine that with fMRI, repeat the observation in terms of this very profound EEG event that was occurring as you went into a deeper state of anesthesia, and then we use the EEG to inform when to do the fMRI analysis. So we line up everybody's EEGs, this is them awake, they stop responding at this point, slow waves start to rise, and then they reach saturation at this stage. And then we can segment the fMRI data into these 3 bins, because at this point they're all asleep. I've got nothing to guide me as to when to do the fMRI analysis, but I use my EEG to inform. So here we see lots of brain activity to the pain and the auditory input. Here we see that once they've gone to sleep, actually, I would go back to the classification tools that Tor's done and we've done, and I would infer that there probably still is a lot of nociceptive processing and pain-like experience, but of course, I will never know. But the point they reach saturation, the brain switches into this isolated state. The EEG spindling pattern tells us that actually the thalamus and the cortex are in a conversation. It's not a thalamocortical switch as we thought. There's not just global shutdown. What happens is something changes at this saturation point of slow waves that prevents external events being routed to the correct parts of the subcortex and the cortex to encode the perception. So this is your point, you would argue, of perceptual unawareness. The imaging has done its job now. We can throw that away and just use the EEG. In fact, we can just use a couple of electrodes and identify where people are at SWOS, and that would be the individualized brain-based marker that you would take them to in order to be sure that they're not going to be aware and they're not going to experience pain, potentially. And not only is the amplitude individualized, but what's really satisfying is the amplitude simply correlates with how much grey matter you've got. So you've got this lovely relationship between how much grey matter you've got. If you've got more grey matter, you make more slow waves. And we know that grey matter degrades with age, and so again we've been able to show that not only can we see this slow wave activity saturation phenomenon across different anaesthetic agents in routine clinical care, it also correlates negatively with age. This starts to explain an awful lot to my anaesthetic colleagues about observations they have about demented brains, elderly brains, babies' brains, which of course are all very different. So even if you take a bunch of 50-year-old 51-year-old women like me, we might be the same height, weight, sex and age, but our brains are really quite different, as we know. And what you want to be doing is manipulating the individual brain, not just going on demographics of the body. And so we have a patent on this, which we now have approved in China, and we're going through with the States, and we've just developed a real-time algorithm to titrate people immediately to SWOS in real time, and we're just about to start this summer in the operating room actually using this in anger. So again, really clinical translational opportunity, but also experimentally tells us where to go to in order to try and understand the neural basis of perception, because we know that if you take people to this SWOS, interesting things happen in the brain that we just haven't unraveled yet. So there's a suite of basic neuroscience opportunities for us to explore there as well. We can go even earlier, though. What was going on when they stopped pressing the button? We know that they didn't stop pressing the button because they couldn't move. We had motion artifacts to know that they were still able to move. We hadn't given them muscle paralysis agents. They made a decision not to press the button when that painful or that auditory input was given. And so what we thought was maybe they've chosen not to, because although that event is happening and at one level their brain is processing it, there's a flip between extraceptive and interoceptive awareness, and this event is not happening to me. So if it's not happening to me, I don't press the button. So it's a loss of selfhood. So what we did is we went back to the point at which they stopped pressing the button. We analysed just the few trials to the pain and the auditory data before, and just the few trials after, and asked the question, is there a brain region that commonly switches off or deactivates, common, irrespective, agnostic, to what the sensory input was? And the region that we identified was this anterior insular division. So that's pretty interesting because, again, it's got these von Econo neurons. It's been thought of as the interoceptive awareness area. We'd shown several years ago that, indeed, this is where you integrate information about saliency of pain to bias you towards deciding that this event was painful or not. The anterior insula is a really interesting hub. And this, again, we think is a very interesting, very early point that you could manipulate in terms of awareness. And you don't need to maybe go as deep as SWOS in order to deal with true suppression of the brain for pain, because they're going to have opioids on anyway. If you just want to eliminate awareness, you could go quite light and you could manipulate the structure here. So again, I'm sharing this with you because I think there's not enough people basically in the brain imaging world working in the context of anesthesia, and there's an awful lot of interesting ways that you can manipulate and probe the brain and discover all sorts of things about networks and perception that I think would be very informative. So flicking to, again, the chronic pain side of things again, I just want to finish off by telling you some other work that we've been doing in the context of what holds people in chronic pain. The big things are when you damage those A delta and C fibers, when you have injury, unlike most other damage to fibers and nerves, say your auditory nerve or your optic nerve, you wouldn't have that sensation of vision or hearing. The odd thing about the pain system is when you damage those A delta C fibers, they switch on. They just start firing. So ectopically, you've got this constant ongoing pain. You then have amplification or sensitization in the central nervous system that makes it worse. You then have maladaptive plasticity. We see this a lot in phantom limb pain. And increasingly, we think you actually fundamentally, as you've developed to adulthood, have a central nervous system that's ill-disposed to deal with injury, and you're going to go chronic right from the get-go. So you have a heterogeneous group of patients. What's interesting is, irrespective of that heterogeneity of patients, they share symptoms. And one of the big common ones they've got is ongoing pain, constant tonic ongoing pain. The problem is we can't look at ongoing neural activity in the context of bold imaging. It's very good for looking at the hyperalgesia, the allodynia, key symptoms in chronic pain, sensitization, amplification, because we can poke and we can prod and we can get our bold activity. We can maybe look at a bit of spontaneous pain by looking at resting bold connectivity and looking at the communication in different brain regions in terms of just ongoing activity. But if you really want to look at the big one, the tonic pain, you need a different method. You need a method that will allow you to quantitatively measure neural activity and either look at changes in that over time or even in the same session. And arterial spin labeling, quantitative cerebral perfusion imaging is such a tool that really is beautifully placed to do this. And I'm just amazed at why, as an imaging community, you're not using it more. It's not as simple as just it's an alternative to PET, because it's got more paradigm opportunities than PET. So again, if we just think about the spontaneous activity, there's a lot of groups been looking at that in the context of chronic pain. There's a nice paper that's just been published in osteoarthritis, again focusing on the anterior insula, showing that in pain in osteoarthritis compared to controls, widespread network disruption in those resting state networks, mediated and causal by that anterior insula driving changes there. But again, over the years, several groups, including ours, have been trying to pioneer and champion, so this is lovely work done by Randy Golub's group and Marco Loggia, Matt Howard's group in London, and Steve Williams, using even decoding pattern classification to use this perfusion imaging to give us a window into ongoing pain. But most of these studies have, again, done it more in a PET design, on and off. What we wanted to do was sort of push it a little bit more with a multi-TI method that allowed you to actually really look at the dynamics of pain perception as it alters. So we took a bunch of healthy students, and over the course of about 45 minutes, we just varied the amount of pain. We put chili pepper cream on, it really starts to burn, we can cool it down, and then we can burn it again with heat. So either way, they're always in pain, but they're varying, really simulating the reality of what a patient is doing. And the beauty of this technique is that you can do all sorts of things. You can look at the start, you can look at the top, you can look at a whole video of it, you can ask the question, well, what's just dynamically tracking that changing nociceptive input, which drives a change in pain rating? And what we were able to identify was, again, low old brain, contralateral dorsal posterior insula has been very interested and fundamental to the encoding of this varying nociceptive input that related to a varying pain intensity. It's not the only region that's important for pain. This paper was misunderstood due to not quite understanding the methods or the design. It's not that that's the pain region at all, because obviously you can see all sorts of things coming on and off, as I showed you before. But this region really hung in there, never switched off metabolically for 45 minutes, and its magnitude tracked the change in nociceptive input and the change in intensity. It's interesting that that region popped up, because that's a region that, again, work that others and we have done looking at somatotopy, or even just going in and stimulating in patients who have epilepsy, which is illustrated in yellow, producing excruciating pain in these patients referred to the leg, which is overlapping precisely in the green here, where we identified, again, this ongoing neural activity. And again, overlapping in terms of the somatotopy for the leg, because you have a very nice representation of where the A delta C fibers represent different parts of the body, because it's really important to know which bit of your body is hurting so that you know to withdraw or to attend or to treat it. So you have a somatotopy for A delta C fiber inputs, just like you have for A beta, and again in the leg, it overlaps with our region here. So we've verified this now in a couple of ongoing patient studies. We're reverse translating it into preclinical studies, because one of the problems in preclinical pain models is it's very hard behaviorally to know if your rat or mouse is in ongoing pain. Very, very hard to measure that. So they tend to rely on reflexive, nocifensive measures, and this is all part of the problem of what fuels issues around using preclinical models to be predictive, particularly when you're looking at drug effects, because you're testing them not against the ongoing pain. So if we can reverse translate what we're learning in the human brain, it's a nice example of where we can take something novel and new into the preclinical and help refine and help them guide as to where they could be recording from or looking at to give you that indirect window on the most common symptom that you want to treat. So that reverse translation is born from that. And again, we're also working with our neurosurgical colleagues to go in and try and calm this region down in a patient, because we know this region also connects to quite a lot of other brain regions, stuff that we've done, again, using diffusion and functional imaging in terms of connectivity imaging tells us that this is quite an important hub area. So if we can bring it down, we can calm down quite a lot of that network. So I'll have to come back and see and report to you how those studies go in the next year or so. The amplification issue is, again, a really key one, and this is probably where we spent most of our time over the years. So in the last 5 minutes, I just want to share with you the work we've done looking at this big powerhouse of sensitization and amplification. It's called the descending pain modulatory system. It centers in the brain stems, very old brain, it's unique to pain, periconductal grey, rostral ventral medial medulla, connected to structures like the amygdala, the hypothalamus, the anterior insula, and the frontal cortices. It communicates to the dorsal horn of the spinal cord, where those nociceptive afferents come in a pro or facilitatory way, or in an anti or inhibitory way. So you can think of it as good cop, bad cop. It's serotonergic, noradrenergic in its makeup, and this system and the imbalance in it, too much bad cop, not enough good cop, we now know from preclinical work and a lot of work that we've done is key explanatory factor for what is holding people in these centrally sensitized chronic pain states. So over the years, we've been able to show that indeed this maintains central sensitization amplification. We see aberrant activity in this system across a range of different clinical disorders. We can even use it as a biomarker in drug discovery to show that you've got target engagement. So here is it being suppressed with gabapentin, but not with ibuprofen compared to placebo, when you wouldn't be able to work that out from the behavioral ratings. They all look like it doesn't work. So again, really useful to use as a sort of biomarker or an assay. So the bad cop has been very helpful in that regard. And again, this study that we've just published is in diabetic pain, where we took a group of patients who had diabetic neuropathy. They were matched completely, apart from the fact one group had pain and one did not. So everything about their diabetes or their neuropathy was matched. The only difference was they had pain or not. And then what we were able to show is the more you dial up this facilitatory bad cop, the more it explains the resting bulb connectivity to the rest of the brain in terms of tuning that up, and the more that explains and correlates with their clinical pain variance across the group. And then when the patients were very tolerant and they allowed us to heat their painful legs with hot water bottles, so we drove them into heat hyperalgesia. And again, the more you dial up that, the more it explains the arterial spin labeling, ongoing neural activity, network activity change across the group, and the more it explains the behavior. So you've got function, behavior being explained with two different modalities, bold resting state and ASL, explained by this fundamental aberration in the system, where we've not been able to find out peripherally what distinguishes these diabetic patients and the pain. So again, the answer is certainly a major component centrally. So just an illustration of how one can do it. The good cop has been really looked at, and there's no doubt the good cop is what you use in your everyday situations where you get that free analgesia, when you're distracted from pain, listening to music, watching a film, in the heat of the battle, placebo analgesia. Countless people, including Tor and wonderful people, have done amazing work to unarguably identify that this good cop is the system that you activate when, again, you're distracted from pain. And the beauty of it is that this cascading system that drives that good cop starts with these very frontal regions. And what we've observed, certainly in the studies that we did early years, where we were distracting people and seeing this system come online and explain how they got distraction-induced analgesia, was that it was quite variable. Some people were really good at tapping into it and activating the periconductal grey, and others were not so. So what was it that was variable about that might explain things? So what we were considering was maybe we could drive this, because this is just below the skull, so we could use some brain interference methods to maybe help those who are not very good at naturally engaging this system and help them drive this system. So working with my colleague Charlotte Stagg, who's a great neuromodulator, we did an experiment which is a really beautiful illustration of structure, function, behavior all coming together. So again, we've got chili pepper cream on. People are in a constant ongoing pain. We're using our arterial spin labeling method. So again, it's another verification that this dorsal posterior insula really seems to get interested when you've got ongoing pain states. So this is its constant cerebral blood flow measurement over a 25-minute period to the sham stimulation. And then when we drive the anodal stimulation, we're driving that good cop. We're suppressing the nociceptive signals of the dorsal horn, less comes in, so you feel less pain. So what you can see is tonic suppression of that signal. But what's really interesting is, when you look at the variance in that suppression of cerebral blood flow signal as an indirect measure of tonic suppression of neural activity, it correlates with the actual fractional isotropy between where we're stimulating and the thalamus as the relay. And it correlates with the magnitude of analgesia. So those who had a large amount of analgesia had good structural integrity and had good suppression of that signal, and those who were down at this end did not. So again, you stratified people. You can think of that a personalization of a therapy that's likely to work in some, not so for others. Again, maybe we could keep stimulating people and drive these people down here with poor anisotropy up to the top. We will have to see. But I think it's a nice illustration of using, again, a multimodal imaging approach to really dissect and explore a problem. I'll skip over that because I've run out of time, and just encourage, my final thing is to encourage all of you out there who've not thought about the spinal cord as somewhere interesting to go. You should go there now. Now, several groups, Christian Buchel's group, my group, Kohan Haddad in Montreal, have worked slavishly for about 15 years now to beat this tool into submission, such that we are at a point now where we can get really good quality data functionally from dorsal horn, ventral horn of the human spinal cord. It's not been an easy journey, and there are still developments to progress, certainly at 70, which is what we're pushing at now. But there's no doubt, having done a lot of verification, so again, a lot of work that we've done is verified what you would expect to see in terms of functional activity in the spinal cord, and even cognitive influences, those top-down good cop, suppressing things in placebo analgesia, suppressing the dorsal horn activity when you're distracted from pain. Beautiful work done by Volk Eibert and Christian Spenger in Christian Buchel's group. Is now we're starting to discover new biology. So again, the capacity to look at resting state network and redefine our textbook understanding of the physiology and the neuroanatomy of the human spinal cord. How is it that these different horns are speaking both within a segment and between segments? What is the extent of those top-down influences? We have some very exciting data to show real learning and potentially predictive coding effects in the dorsal horn of the spinal cord. There is things to be discovered there, and I would encourage more people to join, because I think the problem we've had and why the field hasn't progressed as much as it should is that people have this assumption that it's just boring. The human spinal cord is just a relay, and there's nothing really much going on there in terms of modulation. Well, there's an awful lot of modulation peripherally and top-down. It's a really challenging area, so those of you who are more from the physics or the analysis and you want to get your teeth into something, we need more people to jump onto this spinal cord bandwagon so that we can really progress both the imaging and the analysis of this area, but obviously the science too. And I think it's exciting that we're starting to get new biology there. So, in summary, imaging has the potential to unravel the neural basis of pain relief and CNS mechanisms important for both predisposing, maintaining and worsening chronic pain states. I've just given you a little snapshot of the field. There's a lot more I could say, but I think I would conclude by saying, much as I respect Pat Wall, I do believe that it's certainly more than fantasy labels. And with that, I'd like to thank my team and the people that I have the very good fortune of collaborating with in Oxford. So the various people that are driving the different areas of the team. So Andy Segadal in the ASL, working with Tom Ockel, who's one of our physicists. Spinal Cord Folk has now returned to Germany. Joe Kong to Beijing. This is Johanna Venesho, really developing the 70 spinal cord imaging. My clinical team that's doing a lot of the clinical work and the drug development work that I largely haven't spoken about today. And the Anesthesia team is led by Katie Warnaby and key collaborators Saad Jabadli and Jamie Slay in New Zealand, and then great collaborators like Rebecca Slater, who does all the paediatric imaging work, Katja Vik, who does a lot of the cognitive work, and again, I've not been able to share with you our work led by Tamar Macon and Sana, who've developed all the wonderful work on phantom limb pain and maladaptive plasticity. So with that, I'd like to also acknowledge my collaborators and my past group members, some of whom work I've shown you, all the wonderful volunteers and patients who've come and lain in the scanner and been poked and prodded and burnt and infused with various drugs. I'd like to acknowledge and thank them. And also, of course, the funding agencies who have very kindly and generously supported the work over the year. But mostly, thank you for your attention. And once again, thank you to the organising committee for the honour of speaking with you today. Thank you.